Today, we're going on a journey. It's a medical journey, one that starts with a tiny, almost unnoticeable clue and ends with understanding a condition called a vestibular schwannoma. It almost always starts this quietly. A faint ringing in one ear, a little bit of dizziness you brush off, maybe a feeling of fullness that just seems weird. It's so personal, so internal, that it's incredibly easy to just ignore. But sometimes those little whispers are the very first piece of a much bigger puzzle.
And that's really where this whole story kicks off. It's in that phase where the symptoms are so subtle, they could be a dozen other things, or nothing at all.
See, the biggest challenge with a vestibular schwannoma is that its first signs whisper. They really don't shout. Think about it. Gradual hearing loss in just one ear? It's easy to just say, I'm getting older. That ringing sound tinnitus? Oh, must have been that concert last weekend. It's this exact subtlety that can cause a delay in diagnosis, because we're not talking about some big, scary, sudden event. We're talking about a slow, creeping change that's just easy to get used to.
Okay, so those subtle symptoms are the what of the story, but now let's get to the why. What is actually going on inside the body to cause all this? Let's dive in.
So, here it is, a vestibular schwannoma, and you'll often hear it called an acoustic neuroma, they're the same thing, is a benign tumor. And that word benign is absolutely crucial here. It means it is not cancer. It grows on this really important nerve, the vestibulocochlear nerve, which is basically the superhighway for information about hearing and balance between your inner ear and your brain. So how does one of these things even form? Well, think of your nerves like little electrical wires. They need insulation to work properly, right? That insulation is called the myelin sheath, and it's built by these amazing little workers called Schwann cells. A vestibular schwannoma happens when a tiny gene mutation tells these Schwann cells to just go haywire and start multiplying like crazy, building up into a little benign tumor right on that nerve. All right, so understanding what it is and where it comes from is a huge first step. But the next part of the journey is getting a real definitive answer, and that involves a very specific path to diagnosis. To actually see what's going on in there, doctors need some serious technology. And while CT scan might be used sometimes, the undisputed gold standard, the best tool for the job, is an MRI with contrast. That contrast is a special dye they use that basically makes the tumor light up on the scan. The MRI is just so powerful because it can see soft tissues in incredible detail. This means doctors can spot even the tiniest of tumors, which, as you can imagine, is a total game changer for managing it early. Okay, so once a tumor is found, it's not just about its size and its location. So doctors use the system, the Coos grading scale, to classify them. It's not just about millimeters, it's about impact. A grade 1, as you can see, is tiny, just tugged away inside the ear canal, no big deal. But as you move up the scale, it starts to get more serious. By the time you get to a grade 4, it's actually large enough to be pushing on the brainstem, which is, command central for your whole body. This scale gives everyone a really clear roadmap for what to do next. And those decisions about what to do next basically lead you to a crossroads. After the diagnosis, a patient and their doctors have to look at 3 very different paths for how to manage the situation. But hold on, before we even talk about those 3 paths, we have to talk about this, because this is huge. There's been a fundamental shift in how doctors think about this. The old goal was just get the tumor out at all costs. But today, the main goal is preserving function. Things like your hearing, the control of your facial muscles, and just generally maintaining your quality of life. It's a much smarter, more patient-focused way of looking at things. So, with that new quality of life first philosophy, it really boils down to these 3 main strategies. You've got observation, which is often called wait and scan. You've got radiation, and you have microsurgery. Each one has its place. Now, why on earth would you just wait? I mean, it sounds kind of passive, right? Well, it turns out there's some amazing science behind it. A landmark study out of Denmark found something incredible. A huge number of these tumors, especially the little ones, just don't grow at all. Up to half of them might just sit there, stable, for years and years. And that powerful piece of information is why wait and scan is such a valid and common approach. You just watch it with regular MRIs and only step in if you really have to. Now, for tumors that are growing, or if a patient just wants to be more proactive, radiation is a really powerful option. The goal here isn't to remove the tumor, but to achieve tumor control. Basically, you zap it with focused beams of radiation to damage its DNA so it can't grow anymore. Radiosurgery does this in one single high-powered shot. Radiotherapy does the same thing, but it breaks the dose up into smaller sessions over a few weeks. And the third path is microsurgery, which is all about physically removing the tumor. Now, this is not your granddad's surgery. Surgeons use these incredibly powerful microscopes to work with pinpoint precision, carefully teasing the tumor away from all the delicate nerves around it, especially the facial nerve. Preserving that nerve is a huge measure of success. And it's so important to know, the risk from this kind of highly specialized surgery is exceptionally low today. So we've gone from the subtle symptoms to the diagnosis and through the modern treatment options. Now, let's just zoom out for a second and appreciate how far we've come. The story of this condition, going from totally incurable to completely manageable, is honestly one of the great success stories of modern medicine. I mean, just look at this timeline. It's staggering. When this was first described back in 1777, it was basically a death sentence. In the early 1900s, trying to operate was actually more dangerous than the tumor itself. But then you get pioneers like Dr. Harvey Cushing, who just dramatically changed the game for surgical safety. Then came radiosurgery, a non-invasive option, and then the MRI in the 80s, well, that changed everything because you could finally find these tumors when they were small and easy to manage. And it all leads to this one quote from the official guidelines just a few years ago. It just says it all. The whole mindset has shifted. It's no longer a war to just destroy a disease. It's a partnership with the patient to manage a condition. It's all about giving them the longest, best quality of life possible. And that, going from a mysterious fatal problem to a manageable condition with hopeful options, that is the real patient journey.